Greetings. So let's talk about the disorders of sodium. And essentially, when we are doing disorders of sodium, it's either too much, which is hyper, or what we're going to start with is too little, which is hypo. Now, whenever we're considering disorders of sodium, we've got to go through steps and we've got to consider what the fluid status is. Okay? So let's begin. So let's start with hyponatremia. Okay. Again, low plasma sodium, less than 135, right? So what's my decision tree? So first thing I want to do is check my measured serum osmolarity. This is what's measured in my lab. Okay. If my measured serum osmolarity is hypertonic or isotonic. So remember normal is 280 to 300. So anytime it's isotonic, which is 280 to 300 or greater than 300, the fluid is what? My plasma is what? Is isotonic and or it's hypertonic. Now I have hyponatremia, which is isotonic or hypertonic and not hypotonic. This, ladies and gentlemen, is false. This condition is false hyponatremia. We covered it in video 1, the video previous to this one, where this is not a problem of sodium and water. This is something else. Okay? So let's look at it. It's pseudo-hyponatremia. Low sodium should give us low osmolarity, but it's not. Okay, low sodium, if our measured osmolarity of our blood is isotonic between 200 and 300, I check for triglyceride levels and I check for increased proteins in blood. Okay, but those two are the issue. It's not an issue of sodium and water. If I have hypertonicity, where my plasma osmolarity is greater than 300, okay, then I have hypertonic hyponatremia, which is still false or pseudo hyponatremia, right? But usually the issue is that there's something else other than sodium, which is causing increases in osmolarity. Okay, so remember we talked about osmolar gap being a gap between measured and calculated osmolarity and usually associated with ingestion. This is the time we actually calculate the osmolarity, 2 times sodium plus glucose divided by 18 plus 1 divided by 2.8, and actually calculate the osmolar gap, okay, by minusing measured minus calculated. If you look at labs in your hospitals, a lot of time this is given to you, okay? And if that's the case, then it's some kind of ingestion, methanol, ethanol, glycol, mannitol. If not, check the sugar, because the sugar may be so high that it's actually adding a lot to the osmolarity. Okay? And that's false hyponatremia. It's a different problem. It's not a salt, or sodium, and fluid problem. Now, what if you have low sodium and your measured osmolarity is low? This is hyponatremia, which is hypotonic. That's actually true blue, real hyponatremia. Okay? So remember, what were our principles? What were the variables we were going to consider? I'm going to first consider what my fluid status is. Step 1. Okay? So I have 3 choices. My fluid status, I could be low, Okay, you with me on this? I could be high, okay, or I could be normal. Okay, so that's the first thing to check. So what if I'm low? Then I'm hypovolemic. This is hypotonic, hypovolemic hyponatremia, right? If my fluid status is I am hypervolemic, right? Hyponatremic, right? Hypotonic, right? So hypotonic, hypovolemic, hyponatremia, okay? If I am euvolemic, right? My ECF fluid is euvolemia, then I'm hypotonic, euvolemic, hyponatremia. You with me on this? See how simple it is? But I can use big terms and confuse you. It's very simple. It's true hyponatremia and then divided into three parts. First, I'm going to see what my fluid status on the patient is. Let's say it's low. So my plasma sodium is low and my fluid ECF status is low. That means my total body sodium is going to be my fluid times plasma. So both are going to be low. It's going to be really low, right? Remember? Plasma times volume. That's equal to total body sodium. We did that in first video. If both are low, the product is going to be really low. So I have low fluids, which means low arterial volume, and I have low total body sodium. So remember, what was our decision tree? If my fluid is low, I'm going to give fluid. Okay? If my fluid is low, I'm going to give fluid. And if my salt is low, I'm going to give salt. It is interesting now to look at how I'm going to do it. If it's mild to moderate, I'm going to give by mouth or IV fluids, right? Depending on whether it's mild or moderate. And again, I give what? Salt and fluid both. If I'm going to give it IV, it's normal saline, 0.9% normal sodium chloride solution. If it's severe symptomatic hyponatremia, remember that exception? I'm going to give 3% sodium chloride in the ICU. And I'm going to diagnose and treat underlying cause. Okay? Next. Let's say my extracellular fluid status is high, so I'm hypervolemic, and my plasma concentration is low. So here, my plasma concentration is low, and my fluid volume status is high. So when you think about it, if the fluid volume status is 2 highs and plasma fluid status is 1 low, right? Then your total body sodium is going to be a little bit on the high side. And your fluid volume is going to be high, which means your arterial blood volume is going to be high. What are you going to do when the fluid is too much? I'm going to diurese. And I'm going to restrict their fluid. Right? Easy. Sodium is normal to high. So one may consider restriction. Because remember, it's hyponatremia. So if you restrict sodium, in this case, if the fluid is high, it's going to help up the sodium level. So again, you don't have to really think about it. So again, sodium water restriction and then diurese. Take out that water. If it's symptomatic, severe hyponatremia, then it's 3% sodium chloride. If it's mild to moderate, diurese them, get the water out, and restrict their sodium and water, and diagnose and treat underlying cause. Easy, right? Last, this is a little bit of a change. But if they are euvolemic, right, and their plasma sodium concentration is down, what about the total body sodium? That's going to be down, right? Again, total body sodium equals what? Plasma sodium times ECF. ECF is good. Plasma sodium is low. So total body sodium is low. Okay. The arterial volume, because it's the patient is euvolemic, is good. So something to remember. But initially, what is this patient going to get? We're going to give them sodium because they don't have a lot of sodium. So I'm going to give them sodium. But they have enough water, so I'm going to not give water. So give sodium, but not water. Fluid restriction. If it's severe symptomatic, 3% sodium chloride in ICU and diagnose and treat underlying cause. Easy? That's the first step. Now, usually I think this would suffice for most of the testing purposes. If you can get this, you know more about sodium and water disorder than most people and how to apply it. If you can apply this, it's amazing. However, let me give you a little brief insight, just very basic, into diagnosing the underlying cause. Again, that would be differential diagnosis, and this is not covering differential diagnosis. This is just to give you a general principle of how you diagnose. There is a likelihood that sometimes, as we are increasing intensity of our tests with next generation tests, we may expect our nurses to follow what we are doing with certain tests and what are the principles of diagnosing. Okay, so I'll just give you some principles here. So again, if it's hypovolemia and it's hyponatremia, remember they've got their total body sodium is low and their fluid is low. So what are you going to do? I'm going to give them water and I'm going to give them sodium. That's exactly what we did, right? So if their arterial blood volume is low because they're hypovolemic, it's the aldosterone that's going to kick in. Low arterial blood volume means aldosterone, okay? And what's the normal aldosterone response if aldosterone's working good? You should have urine sodium that's low. So if you see hyponatremia and patient is hypovolemic, okay, while you're treating the patient, what would you expect the provider to order? Okay, they may order urine sodium because they want to know, is the aldosterone system working or not? Because if the urine sodium is low, aldosterone is working perfectly. Kidneys are doing just fine. It's extrarenal losses outside the kidney. If, however, the urine sodium is high, hey, that aldosterone's not working good. It's an aldosterone issue, it's renal losses. Okay. Just some basic principle of how we diagnose renal and extrarenal. Okay, and how we separate the two containers out. Let's apply the same logic here. So now we are looking at the second case where the extracellular fluid is too much and the patient is hyponatremic. So it's hypervolemic hyponatremia. So remember, the plasma sodium is low, okay, and your extracellular fluid is very high. So your total body sodium is on the higher side, right? And because you're hypervolemic, your arterial volume is very high. That means your ECF fluid is high. So what does that do to aldosterone? Aldosterone is going to go down so that it can get rid of sodium and water, which means urine sodium is going to be high. Let's take a look. That is correct. urine sodium is again what you're going to check. If its urine sodium is high, that's great because that's not a kidney problem. Kidneys are working perfectly. It's extra-renal, and it's gain of this extra fluid that's not kidney related. It's outside kidney. Could be heart. If, however, the urine sodium is low, aldosterone's not working good. That tells me there's an issue with the renal system, and the gain of this extra water is renal. Okay? Just some basic principles of how we are separating renal and extra-renal. Okay? Last but not the least, what about if a patient is euvolemic? Well, their arterial volume is normal, which means aldosterone is not an issue here. Aldosterone is not an issue here because remember the flow through the tubule is going to be good. Okay? What's going to be the issue? If the fluid is normal and the sodium concentration is low, and remember, so it's hypotonic, euvolemic, hyponatremia, it's hypotonic, ADH is going to kick in. ADH is going to be a big player here. And because the plasma is dilute, because the osmolarity is down, because it's hypotonic, ADH is going to go down because it wants to get rid of this extra fluid. Right? That means the urine is going to be dilute, or urine osmolarity is going to be low. So if urine osmolarity is low, it's dilute urine. Right? Right? Again, the plasma osmolarity is low. It's dilute blood, which means ADH is not going to kick in, and it's going to pee out dilute urine. That means ADH is normal. If, however, urine osmolarity is high, then ADH is abnormal. And that gives that then one of the possibilities to consider is, hey, why is my ADH acting abnormally? Symptom of inappropriate antidiuretic hormone. Syndrome of inappropriate antidiuretic hormone. Okay? So again, that gives you a little insight into this, and that also gives you an insight into SIADH, which we'll talk about a bit when we talk about endocrine as well. Okay? Easy, right? So we talk about how to go through sodium levels that are low and how we first teased out whether it was a lie. In other words, whether it was related to sodium and water, was it another problem? So hyponatremia, if it's isotonic or hypertonic, is a different problem. And we looked at that very quickly, right? We looked at how isotonic would be triglycerides and protein, and when it's hypertonic, it's not sodium, but either glucose or something else, osmolar gap, which is causing that tonicity to be high. If it's isotonic, we divide it into euvolemic, hypervolemic, and hypovolemic. And essentially, we apply the same algorithm, which is if more fluid is there, you diurese it, less fluid is there, you give fluid. Okay? Same with sodium. If it's more body sodium, you take it away, or you restrict it. And if it's too less, then you give it. Okay? We applied our principles of treatment, and then we talked about how the next steps with diagnosing it and whether it's renal versus extra-renal. And that was for hypo and hypervolemia, because that activates the aldosterone system, right? And for the euvolemic system, it's the ADH, which is governing what happens next. And again, when we're checking the aldosterone system, we check the urine sodium, and if it's the ADH, we check the urine osmolarity. We actually looked at it logically. Don't try to learn this. Look at it logically. If it's hypovolemia, it's less fluid. Aldosterone's going to kick in, absorb sodium, less urine sodium. So for hypovolemia, I am expecting less urine sodium if my kidney is working. For hyponatremia, I'm expecting less urine sodium if my kidneys are working. So if my kidneys are working, it's outside kidney or extrarenal where the problem is, right? And vice versa. Do the same for the other one as well. But if you do it logically, you don't really have to learn any of this. You got it. You can just look at the question, look at your patient, apply it, you're good to go. Okay, good. All right, now let's talk about hypernatremia. Now, hypernatremia is too much plasma sodium. Now, can you actually have hypotonic or isotonic hypernatremia? Theoretically, anything can happen, but there's low likelihood of that happening. Why is that? Because plasma osmolarity is 2 times sodium plus some other things. But because sodium is high here, it's going to be hypertonic. So what are we going to do? Exactly the same thing we talked about in video 1 and we did with hyponatremia. We are going to see what the fluid status is. If a patient is hypovolemic, okay, right, and their sodium is high, their total body sodium is going to be on normal to lower side. So if it is too little fluid, I'm going to replace it. If it's too little sodium, I'm going to replace it. Okay, so I'm going to give more free water, 2 up of free water and 1 of sodium up. So that's hypotonic fluid. In real life, give them isotonic fluids. Remember our principles? And our body will actually fix stuff. Diagnose and treat underlying cause. Okay, what if your ECF is high, you're hypervolemic, and your plasma sodium is high, which means your total body sodium is going to be very high? What are you going to do? Man, I got too much fluid. I got to diurese. I got to put them on fluid restrictions. What about total body sodium too high? I got to get rid of this salt. And I got to restrict their intake of salt, right? How do you do this? Remove water and sodium excess by using diuretics. And we're going to talk about these drugs in renal pharmacology, so you can review those. And diagnose and treat underlying cause. Easy, right? Last, tell me, so we've covered hypo, hyper. What's the last one? Euvolemic. Euvolemic, right? So if plasma sodium is high and they're euvolemic, their total body sodium is going to be high. So what are you going to do with euvolemia? Nothing. What are you going to do with total body sodium that's high? I'm going to restrict it. So this patient is going to be on sodium restriction. Okay? That's the big thing with this kind of issue. Okay? And then diagnose and treat underlying cause. Okay? Let's take a look at this. Let's start with this. We're going to do the same thing with it we did in hyponatremia. If the patient is euvolemic, their arterial blood volume is good. So aldosterone's not going to kick in, but ADH will. Why? Because remember, this is what? Hypertonic abnormality. So whenever you have hypertonic, that means your blood is very concentrated. Your ADH would kick in. It's going to absorb water from the urine, and urine is going to become more concentrated. Urine osmolarity should go up. If it does, your ADH is working great. If it's not, ADH is bad. Let's take a look. Okay, again, ADH high, urine osmolarity high, that's normal response. normal response. It's some other loss, usually insensible loss, and we've covered that in a prior video, right? If, however, urine osmolarity is low when it's supposed to be high, that's not normal. Diabetes insipidus. It's one of the things to consider. Again, we're going to talk about this disease a bit more in endocrinology. What do? We give these patients ADH. If the ADH works, right, we give them antidiuretic hormone. If it works, how do you know it worked? It's going to increase the urine osmolarity, right? It's going to get the water to get more absorbed. That means, what does that mean? That means I gave the ADH, the kidneys responded, right? ADH is what? It is in your pituitary, goes to the kidneys, right? And then it acts. So when ADH is not acting correctly, right? So I give ADH and it starts working. That means kidneys are acting fine. It's brain that doesn't produce ADH, right? So this is an issue of diabetes insipidus related to central nervous system, central diabetes insipidus. Same thing. I do CNS and I do kidneys, right? Now I give ADH, it doesn't work. Which, how would you know? Urine osmolarity is still low, okay? Remember, that was the original problem. It's supposed to be high if the ADH system was working. It's low and not good. And it's still low, even after I give external ADH drug. Means kidneys are not responding. It's nephrogenic diabetes insipidus. See how easy this is? Let's see if you can actually do some basic diagnosing. Okay, let's look at hypervolemic hypernatremia. And of course, it's going to be hypertonic, right? But because the extracellular fluid is more, the arterial blood volume is more, aldosterone is the key hormone here. And because you have high blood volume, aldosterone's not going to be working. It's not going to be absorbing sodium. So your urine sodium should be high if aldosterone and kidneys are working. Urine sodium high, kidneys are working, so it's non-renal issue. Versus if urine sodium is low, it's a renal issue. So again, if we have decreased urine, so again, if we are looking at what? Hypernatremia, and it's hypervolemic hypernatremia, right? What's going to happen? Total body volume, so arterial blood volume is going to be high, so aldosterone's not going to kick in, right? And what would that do? It's going to try to get, rid of that urine sodium, right? So you're going to see more urine sodium in the urine, right? And that's normal response. So again, you'd see increased urine sodium, that's normal response, so that's what? Non-renal absorption of sodium in water. If, however, the urine sodium is low, that means it's the aldosterone system that's not working, so it's kidneys that are the problem, right? Easy, right? So I'm going to let you actually apply the last one, which is hypovolemia. Hypovolemic hypernatremia. So what happens when hypovolemia is there? The arterial blood volume is down, so aldosterone is going to kick in. When it kicks in, it's going to absorb sodium and water, so urine sodium should be low if aldosterone is working. So if urine sodium is low in this case, then this is not renal because the aldosterone is working. Otherwise, if it is urine sodium is high, then it's actually aldosterone system that's messed up. Then you see renal causes. Let's take a look. Urine sodium is low, Aldosterone is responding normally. And so again, it's non-renal causes such as exercise and sweating. If actually it is the aldosterone, if the urine sodium is high, the aldosterone is not working and it's renal losses. For example, diuretics such as spironolactone. So see how simple this is, okay? Now that you know this, the question is nursing interventions or things I gotta keep in mind. This would be super easy. Assess patient's extracellular fluid. Assess patient's plasma sodium. And with two of them, assess their total body sodium. Why? Right, because that would tell you what? What do I need to do? If ECF is high, I need to do this. If total body sodium is high, I need to do this. Okay? Assess CNS. Why? Because your symptoms for sodium are related to CNS. Okay? So as their sodium starts to get better, their symptoms should start to get better. Right? So as their plasma levels start to get better, their extracellular fluid starts to come in line, they would clinically improve. If you're giving fluids, assess for extracellular fluid overload. If you're diuresing, assess for what? Extracellular fluid deficit. Why? Too much, too little. Watch out, keep your eyes. If you're restricting water or sodium, okay, keep an eye on the fact that the patient follows that plan and follows the lab and the patient. Follow the lab and the patients. Okay? Easy, right? If you know the basics, there's some very simple information that can help you maneuver through all of this. Let's just do a quick recap. We talked about hyponatremia, and then we used measured serum osmolarity to figure out whether it was false hyponatremia because it's isotonic, because of triglycerides and proteins, or it's hypertonic because of hyperglycemia or ingestion of things like methanol, ethanol, because of high osmolar, and we use osmolar gap and sugars to actually see what was causing that high osmolarity in this false hypertonic hyponatremia. Okay. However, if it's hyponatremia that's hypotonic, then we have true hyponatremia. What did we do? We actually divided this into three categories, right? Hypovolemia, hypervolemia, and euvolemia. And we went through how the total body sodium is going to be and how we're going to treat it based on those three criteria. And then how do we diagnose it? Based on aldosterone for hyper and hypervolemia and for ADH based on euvolemia. Okay. We use the same exact principles for hypernatremia. Okay, with hypovolemic hypernatremia, hypervolemic hypernatremia, and euvolemic hypernatremia. We did what is our first steps to managing it, and then how do we take the next steps and what are we looking at with diagnosing the underlying cause. Okay, and then last but not the least, we checked some of the things that we would do in terms of interventions, which come straight from what we are doing in this treatment algorithm and some very basic things. Okay, that's why uh, all the videos which make fluid and electrolyte easy, if you know some basic stuff and there's a path to put it together, um, it's actually pretty easy. It becomes complicated when you try to take shortcuts without understanding it, because then um, the, the, the shortcuts uh, a lot of times don't apply to patients, and you can't stack principles on top of each other when it comes to shortcuts. So All right. If you need to listen to the video again, please do. Take care.